Well, welcome everyone to Family Medicine Education Consortium Showcase. We are happy to have Dr. Jared Nisley with us from the Penn Medicine Lancaster General Hospital Residency Program. He'll be talking today about primary care and HIV. But in the meantime, I am Scott Allen. I am the CEO for the Family Medicine Education Consortium. And I want to do just a quick introduction about the FMEC for those who may or may not know who we are. I'm happy to see you all here tonight. So we are the Family Medicine Education Consortium. We are a catalyst, convener, and incubator, and we really kind of have three major goals. One is to promote family medicine and primary care as a pathway for medical students. And to that end, we bring about 300 medical students to our annual meeting every year on scholarships to try and learn about family medicine and to meet the family medicine residency training programs. And we do other things like these virtual showcases to help introduce you to the different programs in our region. We help residents do scholarly work and then also transition into careers, helping them figure out where to go next after their training. And we strengthen academic family medicine by helping faculty members at all the different programs in our region connect with each other, do joint projects, learn from each other through learning collaboratives, learning networks, things like that. We cover 14 states and the District of Columbia. That's all in the Northeast US. There's a little map there. It's Ohio to the east and the Virginias to the north. In that region, we have 60 medical schools and about 220 family medicine residency training programs. We do an annual meeting every fall. Our next meeting is in September, and hopefully some of you are going to be there. And if not, this is a great way to learn about the programs that will be there virtually. We do an award series. We have volunteer opportunities and committees, lots of ways you can be involved with us. So my last plea is, if you haven't already, please consider joining us at the 2024 annual meeting, which is September 19th through 21st in Philadelphia at the Philadelphia Marriott. And there is information on our website about how to either register or apply for a scholarship if you're at a medical school in our region. And with that, I'm going to quickly switch over to Dr. Nisley's slides and let him take it away.
Okay, well, good evening, everybody. Thanks, everybody, for jumping on and spending your evening with us. I will introduce myself, and then we can get started talking about our topic for tonight. So my name is Jared Nisley. I am a 2017 graduate of the Penn Medicine Lancaster General Health Family Medicine Residency, and I'm graduated from actually Penn State, and not too far down the road from medical school. I joined the faculty here at the residency directly after leaving residency, and my practice since then has included a couple of things. So I've overseen our inpatient adult medicine service, worked in outpatient primary care, and I've worked for the past 7 years in our comprehensive care clinic, which is our Ryan White funded HIV clinic. So outpatient HIV medicine has been a big part of my work for the last 7 years, as well as educating residents in that field. I actually gave the HIV clinic work about a year ago, because now I have incorporated homelessness and street medicine as half of my work. So that's my current project in my current area. But I still love to talk about HIV medicine. I still get to try to do it as much as I can. Hometown for me is actually also Lancaster, Pennsylvania. So I stayed very close to home for training. I am married and I have 3 kids, and I enjoy baseball, and I just got a kayak. So I'm enjoying kayaking this summer in my spare time. I also have Jess on the call, and Jess is a resident with us. So I'm going to let her introduce herself, and make sure you say something about yourself personally too.
Okay. My name is Jess. I'm a second-year resident at LGH. I went to medical school at University of Maryland, and I went to undergrad at the University of New Hampshire. But I'm originally from Lebanon, Pennsylvania, so just like 45 minutes north of Lancaster. I am going to be completing our HIV area of concentration, so that's why I'm here if you guys have questions about that. Some things I like to do in my free time, I like to spend time with my 2 Australian Shepherd dogs and my husband outside as much as I can, and just spend time with my family as well, who lives really close by.
Jess, did you ever attend FMEC as a student?
I actually didn't. I wasn't sure that I was going to do family medicine until pretty late in my, medical school training, but so I missed the conferences, but I think it's a really great opportunity to learn more about the programs.
Yeah, I just hearing you talk about it, Scott, was a reminder of how core the FMAC experience was for me as a medical student. I went to the conference twice, presented, actually think I presented both times that I went. And just kind of like you walk into that conference and you realize, oh, these family medicine people are my people. This is exactly where I want to be. And these are the people I want to be when I grow up. So I really think fondly about that conference. And I haven't gotten to go as often as I did as a student, but I still think it's a really great place. So let's go to our case presentation. And really the purpose of this case presentation is to just get you thinking about one case that you might come across in HIV primary care and how we might approach it. So to get us started, I wonder if one of you could read our case. Read our case, and then we'll dive into it a little bit. And I will call on somebody if no one volunteers.
I can read. A 33-year-old cis male with a past medical history of anxiety, HIV, and obesity with a BMI of 34, presenting for routine care in HIV clinic. He was diagnosed with HIV 5 years ago on routine STI testing. And he had a CD4 count of 411, 19% at diagnosis, and has been taking bictegravir, emtricitabine, tenofovir, alafenamide, Biktarvy since then. He has also previously been treated for urethral chlamydia and syphilis. The patient had labs drawn prior to the visit. Should I read the labs, sir?
Sure, why not?
Okay. HIV viral load is 2276 copies per milliliter. CD4 is 632, 28%. His RPR is positive, titer 1 to 2. I'm not quite sure what that means. His GC to CT, 3 sites. Is that 3 sites testing negative? I'm not sure what that one is either. And then hepatitis B surface antigen is negative, surface antibody is positive, and his core antibody is negative, and then his glycohemoglobin is 6.4%.
Perfect. Thank you for reading. And thank you for actually well done with the pronunciations of some difficult drugs. And thank you for sharing where you do and do not know. It's some great stuff we can talk about and get into. So this for me is sort of a mashup of cases, but it is really typical of what we might see in primary care clinic as an HIV specialist. And so I think it's a great jumping off point. And maybe Scott, I'll have you stay on this slide, but our question that just to get, as you start thinking about this is when you look at this case, what jumps out to you? And I intentionally made this really open-ended. There's a lot of directions we could go with this conversation, but so I just want to hear your thoughts and hear kind of like, oh, what excites you, what worries you, what intrigues you about this case?
I don't know too much about normal CD4 count trends on antiretroviral medication, but assuming that he was diagnosed 5 years ago and has been on Biktarvy since then, only having like a CD4 count jump from like 400 to 600 kind of jumps out at me.
Mm-hmm.
And the viral load, I think, is a little high, I believe.
It's also high, and I think it's not undetectable, so there's still a risk for transmission.
Mm-hmm. Mm-hmm.
I was going to say this isn't necessarily from a medical standpoint, but more of a public health, social determinants of health standpoint, is that he's previously been treated for other STIs in the past, as well as being diagnosed with HIV. So I would want to make sure that you know, if there's any trafficking going on, or if, you know, he's still engaging in some high risk sexual behaviors, if he's taking appropriate precautions and all those sorts of things, and that he's safe.
Great point.
I would also want to delve further in his other past medical history of his obesity, so lifestyle changes he has made since the last visit, as well as his current anxiety that he's experiencing now.
Spoken like a true family doctor. You're thinking about the whole person.
Just to add to the conversation, I would also wonder how his support system is, and how his family is like. Does anybody else, is he comfortable? I mean, has he shared the news with anybody? Is there someone to support him? So just how he's doing overall.
You guys are doing great.
Yeah, and I guess I'll add, I guess his glycohemoglobin, which I think is A1C, is 6.4%. So it does, I think, put him in the like high end of the pre-diabetic range for A1C. So that would also be something to talk with him about. And so then I think kind of all of these things taken in combination, like kind of means you're going to be talking to him about a lot, which I guess, you know, could be kind of startling for this patient. So it's another thing, I guess, to just keep in mind.
There's definitely a lot to cover here, maybe more than we can cover in one visit with a patient. Anything else that jumps out to you?
I think kind of it's been said a little bit, but since his viral load is not zero, I would just want to talk to him about how he's been taking the Biktarvy, if he's had trouble getting the medicine or had trouble taking it, side effects, you know, whatever. Because if he had been taking it for the 5 years consistently, his viral load should be down. So I would want to investigate that a little more.
Any other history pieces that I didn't provide to you that might be helpful? Jess, you can jump in too, since I didn't
Yeah,
give you any
so
answers to these questions.
sounds good. I think something that would be interesting to like discuss is, you know, how is the suspected transmission of HIV? Like, is this a person who has substance use? And, you know, is this person still with, you know, is this a new partner that this person sexually active at this time? I think, you know, we know that this patient's on Biktarvy, but what other medications, like getting a full history, making sure we're, like Dr. Nisley is saying, not just focusing on, you know, the HIV diagnosis alone, and making sure we're reviewing everything, especially when it's coming to like the A1C. I think just kind of talking about some of the things you guys mentioned you're not sure about. So the GCCT, that's gonorrhea chlamydia testing that they're mentioning, and they are testing at 3 different sites. So I think it's oral, anal, and urethral. Is that correct, Dr. Nisley?
Yeah, urethral or cervical, yeah.
Okay. So, you know, a lot of this is really focused on like sexually transmitted infections, doing that whole screening, but definitely making sure we're being broad and covering everything. And then also not just assuming that, you know, this was a, you know, sexual transmission, I think is important as well.
Yes, so I think you guys covered a lot of awesome things, and there's many, like I said, there's many directions we could go with it. But let's spend a minute talking about sort of some of the HIV related questions or items that you pointed out. So I think to start off with the CD4 count and the HIV viral load, you're all kind of pointing at some important things. So the CD4 count of 411 and 19% at diagnosis is a little bit lower than normal, right? We say that normal is anywhere between 500 and 1500, and usually the percent is close to 30 at normal. So that is depressed. That suggests that he was infected for at least some time, enough to have some effect on his immune system. But we've seen some significant recovery. So the CD4 count is up to 632. And more importantly, the percentage is almost at the normal range. So that's a nice recovery to me. And that suggests that overall treatment has been helpful and effective for him. But you also all pointed out that the viral load is not undetectable. It's not zero. And so that is a real warning sign. And what might, I guess you guys are all getting at what might be going on with that. So you all mentioned, is this person actually taking their medication? I didn't hear anyone say the question of resistance, which is something that in the history of HIV care we've thought about a lot. And it has been a real bugaboo or a tricky point for kind of successfully treating HIV across the years. But it turns out that's been much less of an issue the last 5 to 10 years because of our newer medications, like the bictegravir in particular is an integrase strand transfer inhibitor, one of the newest classes of medications on the market, and it's super effective, very potent at quickly suppressing the HIV viral load, and it has a pretty high barrier to resistance. So it's not very often that we're seeing resistance. Not that we can't, but it's not very often that we're seeing resistance develop to that medication. So it's possible that resistance is the question, but it's much more likely that adherence is the question, and that there's something that's getting in the way of taking the medication. And so asking patients about their adherence and spending time exploring what's affecting adherence is a big part of HIV primary care. And I've done that so many times over the last 5 or 10 years because it's just so critical. It turns out the answers to that question are really broad and they go in all sorts of directions. So you might hear patients talk about side effects. You might hear patients talk about just, I don't care, or I'm depressed. They might say, I just can't remember. I forget every day. Another thing that comes up is the ongoing stigma associated with HIV, and medication can be a reinforcer of that stigma. So questions about the patient's living arrangement, maybe they're sharing a room and their roommate doesn't know their HIV status. And so being seen taking the medicine could be something that communicates their HIV positive status. There's all sorts of reasons why people might be worried about, and that might affect their ability to take the medication on a regular basis. Where do I want to go next? So I think some other comments that came up is that, yes, there's multiple things happening for this patient. So it's really not just HIV. That's the issue here. There's lots of comorbidities, and those things are definitely worthy of discussion too. I mean, he's almost got a diagnosis of diabetes. Like, that's a really big thing, especially at 33 years old. So that's definitely something that you could spend a lot of time on in this visit. And certainly anxiety and metabolic risk associated with obesity is something that we should be paying attention to. And there's interplay between HIV and metabolic risk. The medications affect lipids, they can cause weight gain. So those things are not happening in isolation, right? There might be an interplay between those two that are affecting what's going on. So what do you have any suggestions for, what we could do differently for this patient, or what could be better about the plan for this patient?
I think frequent follow-up visits to gain confidence, to reassure the patient that his well-being is the first and foremost, that we as primary care physicians want. Mm-hmm. Building a trustful bond over time. Yeah,
the relationship is therapeutic, right?
Yes.
Or sometimes you just become kind of the pesky little voice in their mind that says, take your pills.
May also ensure he has access to healthcare, health insurance, transportation, make sure he's picking up medications, keeping up with refills, stuff like that.
Yeah, that is enormous. That is a huge issue. And I find myself asking those questions almost every visit. Are you having difficulty with copays? Was there a pharmacy problem? Did you show up at the pharmacy and they didn't have your medicine because they had to order it because they don't keep it in stock? Those sorts of things don't seem like a big thing, but they really can add up and get in the way. I think Ryan White clinics in general and our HIV clinic has a lot of built-in support. So we have, patient assistance for funding for medications. We can actually help with housing sometimes. We have like hygiene products we hand out. So there's a lot of ways that the clinic can kind of address the social determinants of health that might be affecting things. They can also offer case management to help folks get connected to the healthcare system. So there's a lot of additional supports that happen through federal funding, which are honestly not available everywhere else and many other places in the healthcare system. So it's a kind of a special niche in some ways that makes caring for patients with HIV a little bit different. And that varies state by state. Pennsylvania is a Medicaid expansion state, so we have a lot better insurance coverage. But if you're living in a state that's not a Medicaid expansion state, that can be especially challenging. Any other suggestions for the plan?
I think if this is a patient who you like continue to struggle with adherence to, at some point you could always talk about injectable medications too in the long term if are still having issues with that.
I didn't even have to plant you, Jess. I didn't have to give you the answer. I was wondering if anyone would mention injectable ART. So that injectable ART, or Cabenuva in particular, is one of the newest ART medications on the market. So we're using increasing amounts of it. Many patients love it. It's injected every 2 months in the office, a pretty large volume injection, but really well tolerated and super effective. So I think that is the wave of treatment for the next 5 to 10 years. I think that's going to be making a huge impact on how we treat HIV care. We had talked a little bit about some of the other kind of peripheral issues in this case. So I wanted to talk a little bit more about the syphilis and STD testing. So I think that for someone, this patient, it jumps out to me that they've had a couple of bacterial STIs in the past. So asking about sexual practices on a regular basis and doing so, kind of getting practiced about doing so in a non-judgmental way goes a long way to helping patients kind of tell you what's going on and kind of help you assess their risk and help you counsel them about kind of risk reducing behaviors that they can take. In this case, this patient was recently tested, but asking kind of patients like which body parts are affected or are you using in sex, because it has an impact on how we're testing for gonorrhea and chlamydia in particular. I think we typically think about testing a urethral or cervical sample, but many patients are using other body parts, especially oral and anal, in terms of their sexual behaviors. And so if we're not asking about those things, we might be missing the STDs that are out there. Syphilis is increasingly common, and you all will see way more syphilis in your residency than I did 10 years ago in my residency, and I saw more than 20 years ago. It's really rising, and that's a big challenge across the country. In this case, the patient's titer is positive, and that's kind of an invitation to ask more information, because we have the history that he was treated in the past. He's probably treated appropriately. So what we expect typically is a 4-fold reduction in the titer with successful treatment, but it doesn't always turn to negative. Sometimes it does after treatment, but not always. And so this patient could be what we call serofast, where they stay positive indefinitely. However, this also could be a new infection. So we might want to ask about new exposures or new symptoms, like a chancre, for example. And if this is a new positive RPR, this might be an opportunity, or we might be needing to treat once again. Yeah, I think that any other questions or comments about the case, anything that the case kind of brings out in you as we're thinking about it? Okay, we can go to the next slide. You can think about that. Keep going. A couple more clicks. So, historically, HIV care has really been centered around infectious diseases and kind of the clinical bench sciences in terms of development, kind of investigating the causes of HIV and how to treat HIV. But is moving into the primary care realm, and there's a lot of reasons for that. I think the best reason for that is that really effective HIV care really requires whole person care, and I think this case is a great example of that. This person doesn't just have HIV; they also have a social context. They also have comorbidities, and well-trained family doctors are the folks that are prepared to address all of those things in one place. In particular, I think family doctors are really excellent about doing care of women, thinking about pregnancy care, thinking about contraception, all sorts of things associated with that. Family doctors provide excellent LGBTQ plus care and gender affirming care, which are a core part of HIV care. And we just know how to treat folks who are kind of in their context where they are living. Family doctors are in every community across the country, whereas infectious disease doctors tend to be in big cities or they tend to be in academic institutions. And so it can be a lot harder to get access to specialty care. And so that's why I think that family doctors are really the right place to be delivering a lot of HIV care. Another big part we've already hinted at is the importance of addressing stigma, the importance of addressing kind of eliminating racial disparities and inequality in our society. And these are patients that are particularly affected by those inequalities. So we do this in many other ways in family medicine, and HIV care is one more way that we are working to address those gaps and those inequalities in our society. So let's talk on the next slide a little bit about what it looks like to learn about HIV care during residency. So I think all of you, regardless of where you go to residency, should expect to have some exposure to HIV care in the inpatient world, in outpatient practices. I mean, HIV is fairly common, and you would expect to learn about HIV during your residency training. And that's certainly the case at our residency program. Our family medicine inpatient service admits almost all of the HIV at our hospital. So we typically have a couple of cases a month of someone that's positive, usually admitted for some other problem, but it's an opportunity to kind of become familiar with medications and some of the issues that are affecting people that are living with HIV. But for folks in our residents like Jess who desire to learn more about HIV and sort of go deeper, we use what's called an area of concentration model for residents that want to kind of go deeper and learn more and actually can achieve the HIV specialist certification that's offered through the American Academy of HIV Medicine. So what is an area of concentration and what does that look like? So at a minimum, an area of concentration is 200 dedicated hours of kind of clinical and academic time across the span of the residency. In the case of this one, which is one of our oldest area concentrations and our kind of most set ones, that time commitment's probably actually a lot more than that. So you have plenty of exposure to the clinical scenarios. So what we do is we have 2 kind of month-long electives in PGY2, and most of the time ends up being in PGY3. In PGY3, we actually take one of our continuity clinics from one of our other sites and we transfer it to the comprehensive care clinic that I mentioned. And so, almost every week throughout the entire year, you get to spend a half-day session at that clinic seeing patients. I mentioned before that you'll also run into patients on our family medicine inpatient service. And sometimes in the past year, we've had a couple of really significant cases. We've had 2 cases of ocular syphilis and a case of disseminated tuberculosis, all in folks that are HIV positive. So those are more challenging cases that I really have to scratch my head on, talk to our infectious disease doctors for. But they're great learning opportunities as well. In addition to kind of having elective time at a comprehensive care clinic, the AOC includes time at our STD screening clinic, at addiction medicine or buprenorphine clinic, if you want to, with me on street medicine. Some of our other faculty members do additional time with gender affirming care. And so a lot of our residents are interested in learning special knowledge around that, which is very related to HIV care. Everyone that does an AOC is doing an academic project or a quality improvement project on a related topic. So we will help you cook up and develop something that you're interested in to kind of work more on while you're here. And finally, at the end of residency, you'll have kind of enough experience and enough time to sit for the HIV specialist exam. So many of our residents have gone and practiced HIV care other places in the country. So we think this is a really exciting opportunity. It's not the only way to treat HIV primary care, but it's how we have chosen to do it. And I think it's worked really well. I mean, I think our community is kind of really unique in a way in that it was family doctors, it was members of our residency. They really started offering HIV primary care in the early 90s, the mid 90s, and have really taken the lead in our community so that we have around 600 or 800 people that are positive in our county, and about 90% of them get their care through us. And only about 10% of people are going to specialty care, and typically are actually leaving the county to do it. So it's been really exciting to see family doctors taking that lead. Jess, I'm sure I left some things out about HIV care in residency, and I think this is a good opportunity to kind of pause and say, what questions do you have about what it's like to learn about HIV care as a resident?
Yeah, we have a lot of really great opportunities. Like Dr. Nisley said, I actually treated a patient who had toxoplasmosis on our inpatient service this year too, which was interesting. But I'm definitely happy to answer any questions. Yeah, we do, the area of concentration is great so that we can, get that extra time. And I felt like I really wanted to have like thorough knowledge of HIV care, but I think just finishing my first year, I already, had a lot of exposure to HIV care through our clinics.
Do you work closely with the infectious disease physicians as well, like providing mentorship opportunities?
So, in the inpatient service, we can work with them, depending on what's going on. But outpatient, like all our HIV care is done by our, physicians that are family physicians that work in our comprehensive care clinic, and they're all, experts in HIV care. And my experience has been really like working closely with them. And I don't know, Dr. Nisley, how much you work with like outside infectious disease doctors.
Yeah, I think an example of that. So Dr. Lake, who's the clinic director, also happens to run the county tuberculosis clinic through the Department of Health in the state. And so he has kind of developed expertise around another related area, but tends to be kind of tricky. So Dr. Lake, for example, is really the TB expert for the county. Through American Academy of HIV Medicine, there's a lot of networking that happens. And so, sometimes if I would have a question that one of my partners didn't know the answer to, I think that's actually a really great place to go for answers. Or there's even some national kind of what we call warm lines where you can call to get advice about tricky cases. So I think there's a lot of support in that way. The closest sort of academic center to here would be Penn State in Hershey, which is about 45 minutes away. And they do have a very robust HIV clinic. And I know a few patients that go there. It doesn't just for whatever reason, doesn't happen into our call pattern that we end up calling them very often.
This question is not directly related to the AOC, but can you speak more about the STI clinic, addiction medicine, and street medicine programs?
Yeah, Jess, you want to take any of those?
Yeah, I can talk a little bit about our addiction medicine. And I haven't done STI clinic myself yet, so I know it's a great program we have, but I haven't had the opportunity to rotate because a lot of residents love doing it. With our addiction medicine, we have physicians at the residency who, have been trained in addiction medicine that we will rotate through, clinic with them. We have Suboxone clinic at our program that is actually at our downtown family medicine clinic that we rotate through. So you have a lot of exposure. We do a lot of addiction medicine on our inpatient service as well. I actually just admitted a patient who was going through withdrawal, and we were, working through that with him inpatient and getting him to the ability to go to inpatient rehab after that. So there's a lot of opportunity. And like Dr. Nisley mentioned, all of this kind of goes hand in hand. You'll, do gender affirming care with these patients. I think something unique at our program is we do a lot of prenatal care too with our patients who are HIV positive. I just actually delivered a a mother who had who was not undetected, and managing how we work with her through the delivery process, and treating the baby as well after delivery. So that was interesting, but I'll leave street medicine up to you since you're the expert and the STI clinic.
Yeah, so SDI clinic actually is very closely related to comprehensive care, but it's a Department of Health sponsored clinic that is walk-in, happens. I think it's one night a week right now, but they would like to expand that. They've also purchased a mobile unit. They would like to get rolling with offering screening across the country. They're doing lots of prep. I don't know how much injectable prep they're doing yet, but definitely lots of Truvada prep. And so that is, yeah, mostly Monday nights, but residents are always rotating there because like Jess said, it's pretty popular. So street medicine is kind of my project over the past year. And it is myself and a nurse practitioner we're offering medical care in the streets and in shelters to folks that are kind of facing homelessness, and all the many of them have associated comorbidities and multimorbidity. To be honest, I thought we would see a lot more HIV positive folks on street medicine. It comes up occasionally, but less than I thought. We tends to be dealing with other issues, but yeah, that's been really fun and definitely something that we really want residents to be involved with. So that's an elective option if you would like to do it. We also do evening rounds twice a month. So residents are assigned to do that at least once, but then encouraged to just sign up and go other evenings. And those, I think, are really fun nights.
I can attest it's very fun to be a part of the street medicine and, meet people where they're at, and, get to hear their stories, and then also provide care as best as you can.
Thank you.
Scott, you can go to the next slide while people are thinking about questions. So I put this next slide is a few websites that I've put together that you should know about if you're a student interested in HIV training. So the first website is from the AHIVM website, the Academy of HIV Medicine. So they list all of the residencies out there that offer areas of concentration, and a number of fellowships are on that track. Or on that page. So definitely worth checking out some of the places across the country. We're far from the only place that's doing this. There's probably 30 places on that list. And a lot of very high quality residencies on that list too. So places that we admire and would kind of share ideas with and like to improve along with side. We have our own website for our residency there. And then the last one is a super helpful website. This is the HIV National Curriculum, which is a sort of a module-based learning that is free that you can sign up for. And honestly, it's like the best textbook out there for tricky HIV questions. I'm looking stuff up on that website all the time. But if you're looking to kind of sink your teeth in a little bit and learn a little bit more, that's a great place to start if you have a specific clinical question you want to look up.
If anyone has questions outside of HIV care too about the program, I'm happy to answer them separately as well.
Yeah, absolutely. We can jump into that. I do have a couple of slides about our residency. We can go there if that's helpful, or we can just talk about it. You guys have questions?
I did have one quick question that may be covered in these next few slides, but going back to like the areas of concentration with the HIV medicine, and how there's also some overlap between like addiction medicine. I was wondering if it's possible to do multiple two areas of concentration during the family medicine residency program, or if that's just not feasible with the amount of like block elective time allowed.
It's definitely feasible. I think the HIV area of concentration of our areas of concentration is a little bit more time intensive, like Dr. Nisley mentioned. But some of our other areas of concentration are a little bit on the lighter side. And so you can definitely do both, especially if there's overlap in the two. So like my two big passions are HIV medicine and obstetrics and prenatal care. And so right now I'm definitely doing the HIV area of concentration, but also kind of doing extra time in OB care as well and seeing if I can kind of mash the two together. And I'm actually doing my PI project on training nurses at our like women and babies hospital where we deliver babies on HIV medicine. And so kind of like mashing the two interests together with some of the physicians, the other attendings that work at the clinic who started that project. So it's possible, it's a little bit dependent on like what the two are that you want to do, but I think if they're two that have some overlap or you are really dedicated to getting both fit in, it can definitely do that.
Yeah, I think you have to ask yourself, what am I going to get from doing the area of concentration? So I should say an area of concentration is not required. No one has to do an area of concentration, but many people choose to do it. With addiction medicine in particular, I think that we have a lot of addiction medicine built into the curriculum. I mean, everybody gets exposure to MAT and buprenorphine and leaves with a good base of training and to probably prescribe buprenorphine without doing the addiction area of concentration. So my advisee last year did do the addiction area of concentration, and he really spent a lot of time in doing some lay rotations and extra things because he was pursuing a fellowship. So I think that fit for him. But I would say that addiction in particular is one where you get a lot of exposure without necessarily having to complete the whole area of concentration. But I think that's an option if you really want to do that.
Thank you for answering my question.
So while this slide is up, so Lancaster is, and that's how you say it, Lancaster, is right in the middle of the FMEC region. We are in kind of suburban rural Pennsylvania, about 90 minutes west of Philadelphia, a small city in a fairly large suburban county. I think Lancaster, is a really great place to live, although I've lived here almost my entire life, so I'm maybe not the most objective person to ask that question. But we are, I think, an exciting small city. For a small city, we have got a lot of things going on in terms of arts and restaurants. We are close to a lot of big cities, and there's a lot of interesting and fun outdoor activities to do here. So I think this is a great place to live. It's also a lot more affordable than big cities like Philadelphia or New York. So I think that we also have that going for us too. A little bit more about us on the next slide. We are associated with Penn Medicine in Philadelphia, so that's sort of our academic affiliation, but we are a community hospital and we are an unopposed family medicine program. So aside from some trauma residents that rotate here, we are the only residents in the hospital. We have been training family doctors for almost as long as the discipline has existed, more than 50 years. Our founding program director was Dr. Dervanos, and he was one of the earliest members of FMEC and a big champion of family medicine. And we have continued that theme and that passion even in his departure. I think you've heard us talk about our inpatient services and our obstetric services, so you will definitely spend a lot of time on both of those services and get good at both of those things. But of course, outpatient practice is also the core of family medicine training. And one unique thing we do with our outpatient training is that every resident has 2 core clinical sites, one at our urban downtown clinic and another at our rural Quarryville clinic. And everyone goes to both sites, which we think is really rounds out the experience and leads to really well-balanced training. And we have been kind of consistently well-regarded as one of the top programs in the country. So I think we are a competitive place to come, and we are looking for top-notch students to come and make us better, which honestly is what drew me to this place. So I was a medical student. I rotated here and I saw the residents and I said, that's who I want to be like. And I saw residents kind of inspiring each other and faculty inspiring residents to kind of become the best versions of themselves. So I find this an inspiring place to work. That's why I continue to work here. And I think that you should all look into coming and training here. What other questions are on your minds? I think that's the last of my slides. Did anybody go to Kansas City last week? Talk to Jess or Pam? No? Okay. If you didn't, then FMEC in a couple weeks or a couple months is a great opportunity too. I see you, Cindy. Hopefully you had a good time, and Maura.
I'll put my email in the chat. If you guys have questions, you can always reach out to me as well. I'm happy to answer questions about the area of concentration or the residency in general.
Yeah, same.
I want to thank both Dr. Nisley and Dr. Miller for this great presentation. And, you know, just like they said, the Lancaster program is well renowned, and we get a lot of our leaders for FMEC who come out of that program. And I don't know anything, I didn't know much about the city, but I've been learning more and more. And it is a really unique place, being a fun, you know, great place to live with a lot of amenities, but also close to even bigger places. So any other questions for Dr. Nisley or Dr. Miller? Or for me about FMEC? Great. Well, any closing thoughts, Dr. Nisley?
I don't think so. Thanks for having us tonight. It was great. Great
Well,
questions, everybody.
Thanks everybody for joining. We will post a recording of this on our website in a couple days. And if you haven't yet, please sign up for the rest of these to learn about some other programs. They're all on the FMEC website. So have a great night.